You're on here, right?
Can you hear me? Thanks. I first thank the organizers, Johns Hopkins University, Dr. Kerr, and everybody in the Transverse Myelitis Association, and especially all the patients and families who have come to this very important international symposium. I'm fighting a little cold that worsens my deep south accent. So, because I come from the deep south of the Americas. Very deep. Anyway, can you hear me well? Okay. So, I'm going to present kind of a presentation on transverse myelitis as what I think we are interpreting from Dr. Kerr's talk. You could hear that there are many causes that might produce this. And so I think the best definition in medicine that we use is syndrome. These are syndromes, conjunctions of symptoms and signs which produce a disorder. So transverse myelitis is a syndrome of spinal cord dysfunction in which most of the functions, motor, sensory, and sphincters, are compromised either completely or to some degree, and by definition below a level of dysfunction, below what we call a truncal level or a sensory level. Usually, the worst disability occurs about 10 days, and by definition we will see that usually we define transverse myelitis when the disease does not progress over a month. There is damage in both longitudinal and horizontal planes of the spinal cord, and all functions are disturbed either completely or to some degree. Patients often present with prodromes. Which are the prodromes? Prodromes means what precedes the syndrome. So malaise, a cold like I have today, knock on wood, chills, fever, etc. Then patients might develop more specific neurological complaints, including paresthesias, so tingling, paraparesis, weakness of the lower extremities, lots of pain, backache usually, sphincter dysfunction, bowel or bladder disability. And the degree of paresis varies between slight weakness and total paralysis. Patients come to the emergency room usually, and so we examine them there. Often, not always, early in the disease, the muscle tone is decreased, what we call the phase of spinal shock. And then spasticity develops, but not always. Neurologists are notorious for examining deep tendon reflexes. We go with a hammer. And initially, during the phase of spinal shock, the reflexes might not be present there, but they might be very brisk. We look for plantar responses, what we call looking for the Babinski sign. Sometimes it's there, often might be there, and by definition, what we call about truncal sensory level. Regarding that truncal sensory level, in fact, as we saw in the previous slide by Dr. Kerr's presentation, about 80% of sensory levels are in what represents the thoracic cord, and about 10% either in the cervical or in the lumbar. Now, when we reviewed this syndrome of transverse myelitis, I will say close to 10 years ago, and when the first paper on transverse myelitis were coming, and if you look at books that are still, very notorious books, but they quote all findings, people were, I think, touching transverse myelitis with multiple sclerosis. And that really, I think, created a confusion. And when looking backwards, I was very impressed when I was a fellow at the NIH in 1983, when I saw the paper by Berman, Kahana, Zilber, Shaul Feldman from the state of Israel, where they have a national registry for these disorders, And they say, well, not everybody has multiple sclerosis, and we look very carefully at that paper. I think that was a milestone paper then, the paper by Berman, from which we adopted the clinical criteria on how to define this syndrome. So another paper that was important was the paper by Roper from Boston. At that time, he studied 52 patients. And he tried to predict how the patients will evolve. And he found that patients with acute onset of symptoms had tended to have poor prognosis, and they presented 4 types of symptoms that were important. Paresthesias, so the tingling, pain, weakness, and urinary retention. In that study, 37% of patients had a history of a previous infection. 13% of patients had a final diagnosis of multiple sclerosis. But the presentation and the types, the causes that produce the different syndromes were not well analyzed. The same in the paper by Berman. They did not, at that time, they were not able to sort what causes which, I mean, what kind of etiologies might be involved. Knowing that, and which are the possible etiologies we are talking about? We are talking about what we prefer to call it para-infectious, meaning is the germ, the virus, or the bacteria directly producing a disease in the spinal cord, or is the immunological reaction to that invasion which produces the disease? That's still not completely known, and so I think the term para-infectious, something around an infection, might be the most appropriate. Post-vaccinal, after a vaccine, autoimmune, MS, Devic's neuromyelitis optica, paraneoplastic, and vascular are among some of the possible etiologies related to transverse myelitis. So, based on that supposition, we studied with my then resident, who we trained in New Mexico, Dr. Jeffrey, who won the award for this paper, and then Larry Davis from Hopkins originally, and myself. We tried to study retrospectively 33 cases well-defined of transverse myelitis by going into the 5 major hospitals in the city of Albuquerque, a city of about 500,000 people, and looking at records over 30 years with specific focus over the last 10 years of those 30 years. And our goal was to try to see whether we could differentiate cases of transverse myelitis by causation, by etiology. I'm not going to dwell into this, but many of you will know that a retrospective study has its limitations, but at least we set a beginning for what I think we should do now: prospective studies, registry studies, better studies in the new millennium. Our objective was to try to estimate the incidence of transverse myelitis. That was a secondary objective. The main objective was to see whether we can distinguish syndromes by clinical criteria, by imaging features, and by CSF parameters. We developed diagnostic criteria. One of the things I was taught by one of my mentors when I was a resident in Cleveland Clinic is, you want to ruin your career, try to cure MS, and try to develop diagnostic criteria. Anyway, I didn't want to do this, but life takes you to this. It takes you to this, because at some point you have to revise the records, and you cannot include everything. You have to sort priorities. Essentially, the criteria are very similar to Berman's criteria. These are essentially the Berman's criteria from Israel. So, patients, how do we define transverse myelitis, at least then? Acute or subacute motor, sensory, and sphincter dysfunction with a spinal segmental sensory level. There is a rare syndrome called Elsberg Syndrome that binds these relatively rare conditions, transverse myelitis, if you want to call it rare, with sacral radiculomyelitis, which appears to be a little more form of Guillain-Barré. And what happens is that many times in the initial evaluation of patients, we are not sure whether a patient has a transverse myelitis or whether a patient might have an acute idiopathic polyradiculoneuropathy, which is a Guillain-Barré syndrome. And we will talk about that, and Dr. Griffin, the chairman of Hopkins, is going to talk about Guillain-Barré as well. But this is, I think, the boundary between one and the other, usually related to HSV, herpes simplex virus type 2 infection, with a relatively good prognosis and with the possibility of treatment with acyclovir. Bacteria have also been related to transverse myelitis. Bacteria has been also implicated by a few groups in the country, one group from Tennessee, on the possibility of MS, like for instance chlamydia psittaci. And antibiotics can be given if you really detect titers of chlamydia. Borrelia, Mycoplasma pneumonia also has been related to cases of transverse myelitis, also in children, and for that bacteria we have treatment with tetracycline, with what I'm taking today, Citromax for my sinus infection, etc. Yeah. And finally, parasites. We shouldn't forget them, because when I was a faculty at New Mexico, I got CPC. Dr. Davis prepared one of these killer cases in which we have a patient with transverse myelitis related to amoebiasis. The patient was swimming or injected drug. He was a patient that was a drug addict, injected a little drug with contaminated water from one creek next to the Rio Grande, and got the most crazy amoeba you can get, and developed transverse myelitis too. So we have these cases too, sometimes come to our hospitals. Now, relationship with multiple sclerosis, a very complex topic. Transverse myelitis might be a presentation of multiple sclerosis. How often? Controversial. This number is not only 42. It ranges according to whoever did the study. It can go from very low percentage to a very high percentage. Often, patients with MS, as we expected, might have a chronic, recurrent, or a polyphasic course, and also a progressive course, ultimately when they develop secondary progressive disease, or sometimes in primary progressive disorders from the beginning. Another type of transverse myelitis related to vascular events. This is a very peculiar syndrome that we learn when we go to neurology school. It's the syndrome of the anterior spinal artery. Because it's anterior and because the motor function is controlled by the anterior horns and the corticospinal tract, especially the ventral and the dorsal, are mostly irrigated by the anterior spinal artery, patients with the anterior spinal artery syndrome get weakness, get paraparesis without too much impairment of the deep sensation, proprioception, vibration, and that's what we call acute onset of motor symptoms with dissociated sensory symptoms, with not too many symptoms. And that's usually a very dramatic event, producing paraparesis usually, and in many cases the etiology is not known, sometimes related to a spinal angioma or a cavernous malformation, post-infections, sometimes related to spinal artery occlusion, and lately also found in aerobic instructors. We have found a few patients with embolism of the nucleus pulposus of one disc, producing acute occlusion of the spinal artery, producing this kind of transverse myelitis after a very kind of maneuver with the spine, contortions, yoga, whatever. So it's not very common, but we have seen it too. Another type of cause that can produce transverse myelitis is that relation to autoimmune rheumatological disorders. The most common is lupus, but also patients with mixed connective tissue disorder, primary systemic sclerosis, what we call scleroderma, Sjögren's syndrome, and a multiplicity of diseases that are seen by my colleagues, the rheumatologists, can also be related to transverse myelitis. Here we have good laboratory. Laboratory is very helpful in diagnosing these syndromes. We use antinuclear antibodies, double-strand DNA, soluble nuclear antigens, anti-Rho, anti-SSA and SSB, rheumatoid factor, PTT and anticardiolipin for lupus related to cardiolipin antibodies, and also evaluation with the cerebrospinal fluid. Among the most common ones within the rheumatological profile is lupus myelitis. And it is said that 17% of patients with lupus transverse myelitis present with transverse myelitis as the first symptom of lupus, with fever and related to thrombotic complications and probably the production of soluble antibodies circulating immune complexes, producing occlusions in the spinal cord. But the pathogenesis is not very well known yet, and more research has to be done. And finally, before I go directly into the study we did in New Mexico, one of the topics that our group has been working for many years, 10 years or more, is the Devix neuromyelitis optica, a very exciting topic because it is not really exactly the same as multiple sclerosis, and we are working very hard on understanding this syndrome. In multiple sclerosis, at least in classic multiple sclerosis, patients have plaques, white matter abnormalities in the brain, in the brainstem, and or in the cerebellum and in the spinal cord, and often oligoclonal bands. About more than 80 or 90% of patients with MS usually end up having oligoclonal bands. But in Devix neuromyelitis optica, which might recur, is not only a monophasic disease, but might recur, the patients do not have plaques in the brain, brainstem or cerebellum. Mentation, intelligence is usually preserved, it's perfect, and the patients develop optic neuritis, either in one eye or both eyes, and transverse myelitis, which often relates to a long lesion in the spinal cord, not a lesion over 1 or 2 segments, but a long lesion over more than 3 segments with very acute disability, with no oligoclonal bands. We will hear more from my dear colleagues from the Mayo Clinic about this syndrome. Unfortunately, we are working together with them in trying to understand this syndrome better. So, going back to the study, to finalize my presentation, I will present what we found about how can we distinguish syndrome of transverse myelitis by etiology and the incidence estimation. In Israel, Berman found that the transverse myelitis incidence was approximately 1.3 million per year. In New Mexico, over 500,000 people, we estimated the incidence much higher, 4.6 million per year. Why the difference, we still don't know. But it's likely that these numbers are even under-registered, and that with prospective studies we'll find more cases. So this is not that rare. We couldn't look at all the etiologies. So for that study, we focus on 4 subcategories: parainfectious post-vaccinal, MS, spinal cord ischemia, and idiopathic. And this is the diagram from our paper. 46% of cases were related to parainfectious or post-vaccinal. A majority. So supporting what we have read in Berman's article when I was at the NIH, not all the cases are MS. And so that puts this syndrome in a different category. 21% had MS. 21% we couldn't find the etiology, and a minority with spinal cord ischemia. And I can tell you that those patients with spinal cord ischemia tend to be a little older, and in our cases tend to be a little more men than women. Let's look at these plots that I try to simplify from my paper. This is percentage of patients. These are the 4 subcategories. Let's look at spinal shock in red and spasticity in blue. We found that patients that had a parainfectious transverse myelitis, about 53% of those cases had initial state of spinal shock versus 0 in patients with MS. So in our series, which was relatively small and retrospective, if you just leave that away, there is a difference in how we are going to differentiate this. In our cases of transverse myelitis related to MS, no case was found with spinal shock initially. However, in patients that were related, transverse myelitis related to multiple sclerosis, about 80% of those patients had spasticity versus only 30%. So at least we could attempt to differentiate syndrome by a relationship with etiology. In cases with spinal cord infection, spinal cord ischemia, about 66% had initial state of spinal shock, and in cases of idiopathic that we still didn't know, only 16%. And in brown, we look at the sensory level. We look at migration of sensory level, whether that sensory level changed with the evaluation of patient over time. In 57% of patients with parainfectious, a level change. In MS, it changed less. And we will look at that regarding imaging. And in fact, in many of those patients in which we had imaging with a parainfectious or idiopathic transverse myelitis, and this is from a patient with Devig's neuromyelitis optica, the level of spinal cord abnormality was quite long, sometimes even very swollen, and we thought maybe there was a tumor there in the spinal cord, often with cavitation, with necrosis, involving long segments of the spinal cord, sometimes up to, I will say, 5, 6, 7 segments, often more than 3 segments. In patients that end up having transverse myelitis related to multiple sclerosis, it's customary to see, if you see lesions in the spinal cord, 1 segment or no more than 2 segments, a kind of more defined small lesion with enhancement. We then look at CSF. And in our retrospective study, cells and protein didn't help, but oligoclonal bands did help. And patients with MS, when we see them in clinic, they say, oh, Dr. Mandler, I had my MRI, I had this. Do I still need a CSF exam? And although we don't do it for absolutely everybody, we often do it because sometimes we don't know. MS is also a syndrome and varies according to the different type of MS. And in MS, in most of the patients with transverse myelitis, not in most, but in 64, we found, in 60%, we found oligoclonal bands. But we didn't find oligoclonal bands in any of our parainfectious or post-vaccinal transverse myelitis patients. And finally, probability of recurrences. As expected, yes, we did find it in patients with MS, but we also find it in patients with parainfectious. I think that this number, which is 14%, should be seen as a little water in the vase and not 3/4 of the vase empty. This is something that we need to study more and that we need to prevent any relapse in most of the patients. We don't want patients to relapse, and there is more research to do in this respect. And of course, we will hear more from my colleagues on how patients with Devig's neuromyelitis optica also relapse, or might relapse. So in summary, to finalize, we think from this retrospective study that patients with parainfectious transverse myelitis appear to be weaker on the initial exam and suffer spinal shock more frequently. They were likely to have more back pain, and they were likely to have a more long ascending level of sensory dysfunction, while patients with what end up having MS-related transverse myelitis, although in the first attack you cannot know, more often had numbness and may be paresthesias, and they tended to have more spastic paraparesis, even initially. Regarding imaging, patients with parainfectious or idiopathic transverse myelitis tended to have a long lesion in the spinal cord. Patients with MS, a more focalized lesion. Patients with parainfectious transverse myelitis had, regarding bands, they didn't have oligoclonal bands in the CSF. Patients with MS tended to have the bands in the CSF. And finally, regarding prognosis, we didn't have enough cases, but I think registry database will help us a lot, and working together multicentrically within the country and with other centers in the world will make us understand better about the prognosis. But in terms of recovery for ambulation, while patients with parainfectious transverse myelitis tend to have a very acute syndrome with acute spinal shock and maybe need for indwelling catheter initially in the hospital, in the long run tend to recover a little better. Patients with MS that we saw then tended to have a need for catheterization for more long time. But remember that we did that study when we didn't have sufficient medications for multiple sclerosis. We have now a number of medications for MS, and so it is time in the new millennium to reevaluate all this again. And finally, a flow sheet. What do we do with a patient with transverse myelitis when it comes to the emergency room? Patients come with acute paraparesis, with all the syndrome. Immediately, we do an imaging study, brain, spinal cord. We have to be sure there is not mass lesion compressing the cord. If it's positive, we have to call neurosurgery. If it's negative, positive, we call neurosurgery. Negative, we never take it for granted. We want to be sure patients don't have the Guillain-Barré syndrome, which is a little different. We might treat it sometimes about the same, but usually a little different also. So we call EMG, we do spinal fluid. If we don't feel the patient has Guillain-Barré, and sometimes it's not so easy to do it, we think the patient has a transverse myelitis. And we do spinal tap, and we look for all the viruses now with PCR. We look at VCV, we look at HIV, we look at HTLV1, we look at varicella zoster, etc., etc. If we look at mycoplasma, we look at bacteria, we look at tuberculosis when appropriate, we look at chlamydia, etc. We treat them specifically if we can. If we cannot treat specifically, we give Solumedrol, high-dose Solumedrol IV, and more studies, prospective studies, will ultimately tell us whether this treatment is effective, but until we don't know, we'll use it. And then we modify the therapies necessary, because sometimes we find another thing, but we really take good care. This is the acute care, the chronic care, multidisciplinary centers, like what we heard, like the centers we have for treatment of MS and ALS, with simultaneous PT, OT, rehabilitation, sexual treatment, etc., etc. Thank you very much for your attention, and I hope you have questions. Thanks.